Hi, my name is Pam Colleen, and welcome to my podcast, Circadian Reboot, where we discuss everything circadian. And today I'm thrilled to announce that we have Dr. Jim Phelps on the show. Dr. Phelps focused his psychiatric practice on complex mood disorders for over 20 years. In addition to full-time patient care, from which he is now retired, he has published multiple articles on bipolar disorders and psychiatric consultation in primary care. He served as research editor for the Psychopharmacology Institute and Psychiatric Times. He founded the website psycheducation.org, updating it for over 20 years, and recently a simpler website for primary care, depressioneducation.org. These sites provide no-cost information on diagnosis and treatment of mood disorders and led to internationally published books, Why Am I Still Depressed? For patients and families, and a spectrum approach to mood disorders for professionals and highly interested lay people. Along the way, Jim also taught skiing, sailing, and whitewater kayaking. He lives with his wife and dog in a garage full of boats in Corvallis, Oregon. So thank you for joining me today, Dr. Phelps. It's a real pleasure to have you here. One of the reasons why I wanted to invite you on the show is because a lot of people who are struggling with mood disorders are so unstable. It's very difficult for them to understand some of these non-pill regimens that you discuss. And so we'll get into some of the medications that you might use to help stabilize people with severe mood disorders. But I'm excited to share with people your approach using natural therapies that are virtually free or very low cost to help stabilize their moods. There's a lot of people out there really struggling right now. And so I really want to share your regimen with people. And again, you offer it for free on your website, which is very generous of you. But maybe we can talk about a backstory here as to how and why you started noticing these natural light, dark therapies to help people with mood disorders.
That's an interesting one, Pam. How far back do I need to go here? Thinking, well, I started working, especially with people with complex mood problems, many of which turned out to have a bipolar component to them. So I got really interested in bipolar disorders and started reading a lot about that. Exactly when I figured out, hey, light and darkness really matter. Frankly, I'm not sure. I certainly was interested in that concept by the time I learned, as you have learned, about blocking blue light with amber lenses. So I know I was really interested in it by that time. And then I learned, I think this was about 2002 or so, that this brand new finding had come out that blue light was the only light that sets circadian rhythm, or almost the only one. It's not quite 100%. So if blue light is the light that sets circadian rhythm, then blocking it would create physiologic darkness, or so it seemed. And then, oh yeah, I know. You might have to edit this. There was a study, a single case report from the National Institutes of Mental Health, led by a fellow named Tom Weir. And that study was the one that said, hey, look, we've got this guy who's had this really unstable mood course for years. We brought him into the National Institutes of Mental Health and had him just stay in the NIMH, which they did at that time, and tried this drug and that drug. And then they finally tried what they called dark therapy. And that study, I can look it up for you and send it to you. That was must have been 2004 or something like that. So what they showed was, okay, we're going to take this guy and we're going to put him in a dark room for 14 hours out of every 24, they said. And I'm not sure if you've ever seen this graph, but it's a striking graph. His mood is going like this, and then they start doing this dark therapy, 14 hours of enforced darkness with his consent, put him in a dark room, no phone, no lights, no nothing for 14 hours every 24, and his mood started to stabilize very quickly within a couple of weeks. They finally said, okay, that's clearly better. Let's see if we can get by with 10 hours of darkness. So from 8 p.m. to 6 a.m., I think, was what they were doing the following morning. They continued the enforced darkness, but down from 14 hours to 10 hours. And with that 10 hours of darkness, his mood not only stabilized, but got more stable and stayed so for months thereafter. No medication changes, just the addition of dark therapy. That article, that was what started it for me because, oh, wow, this is like a mood stabilizer without any medications. And it worked in someone who tried everything, all this other stuff. So I was very interested in that and started becoming more deliberate about recommending careful management of light and darkness for my patients. And I thought I was seeing, yeah, this is helping. And then I came upon that article from Dick Hansler saying we can block blue light with these amber lenses. And I thought, oh, wow. So you can make darkness without having to have real darkness. You can have virtual darkness. This is going to be a great tool. And I went and talked to Dr. Hansler, um, whose story it's just a wonderful story of we've been making lights for years. Maybe we've been hurting people with these things. Maybe we should make like anti-light. And so I got a couple of their lenses and started handing them to my patients saying, well, try this, see if this makes any difference. And it seemed to make a big difference for about half the people to whom I gave those lenses.
Wow,
So
that's an incredible story. Yeah.
that was the start of it. Um, and then a nurse practitioner who was working with a sleep lab found that, oh, as much as I admire Dr. Hansler and his colleagues, their glasses cost 50, $60. You can go to Airgas, the company that makes welding glasses for welders, and they have a store right down the street, and you can buy a blue blocking lens for $10. So we started sending our clients, both the nurse practitioner and I, to Airgas to go get lenses. And I went down to the Airgas shop and told them what we were doing, and they were remarkably supportive and sort of amused by the whole thing. So they were selling tons of amber lenses at our local Airgas shop. Somewhere around there, I said, okay, I'm going to get a little grant from our hospital and buy a bunch of amber lenses, and we'll keep them in our front office. And every time I tell this story about darkness and light and amber lenses, I'll say, okay, go to our front desk and you can buy them from us and leave with your amber lenses today. And just give us $10 and we'll just keep replenishing our supply. So we were basically pumping out amber lenses nearly every time I saw someone, because here's a tool that can help modulate mood without medications, zero side effects, $10 cost. There's nothing in the medication panoply that is even close to that. So that's how it began.
Oh, that's fascinating. I've been doing this educational component for about a year now, telling people, use the amber lenses and dim your lights at night and go to bed at the same time, get up at the same time, basically get into a good rhythm every day, which, we'll talk more about that. Interestingly, I came across some extreme cases of darkness therapy where people go into like a cave, and these are like retreats. And it's a sensory deprivation approach, which I think is, pretty extreme. If people want to try it, that's fine. But what you're talking about is far more practical to try and basically fix your rhythm. And part of what is being addressed here is the melatonin component. Is that right?
Well, that's true. Melatonin is a physiologic marker of your circadian rhythm. And so when you strengthen and reset your circadian rhythm, you can see that manifest in melatonin levels. Melatonin doesn't make you sleep. Melatonin is synthesized when your body is ready to try to sleep, when your circadian rhythm says, go now, sleep. So melatonin is a marker. Um, and so the onset of melatonin production, as you have probably reviewed on your program here, the onset of melatonin production is a really strong indicator of where your circadian rhythm is.
Okay. And
What are you noticing when people are extremely unstable? How do you get their attention? Because they might try this for a few nights and it doesn't catch on right away, that they don't feel the benefits potentially for a while. I've seen people reset their circadian rhythm, and within a few days, they're sleeping better and feeling better overall. But what about the more extreme cases of bipolar or depression?
Well, frankly, I was basically at one time I was taking money from pharmaceutical companies to give this talk that I've been giving about bipolar disorder for quite some time. And they became quite generous with the amount of money they were giving me. And I thought, well, this is a great deal. I'll take the money from the pharmaceutical companies and I'll buy amber lenses and give them away. So I was giving out amber lenses. This ended up leading to a paper that I wrote about, the first paper that I wrote about using amber lenses in bipolar. Um, well, so with free amber lenses, I could just hand them out and say, here, take these things, see if they work. If they don't, bring them back. People rarely brought them back because I think they were using them in kind of specific ways we can talk about. But on the whole, what percentage of people to whom I gave these things came back and said, nah, that didn't do anything? Um, Almost 50% said, nah, no effect. And I'd have people coming back like within a week of having handed them these glasses. But the other 50% came back and said, this is amazing. When I wear these things, I can fall asleep an hour or two more quickly. And I think I'm sleeping better. So it was about a 50% response rate, I would say. Now, I guess to answer your question, Pam, what brought people's attention was waving these things around in my office and saying, I'm going to give these to you. You can try them. Like, so what's the downside of this for me? He's going to put it in my hand. That that I think actually is a really essential step for clinicians doing this is to make it extremely accessible. Like here, take these, or like we ended up in our office here, you can buy them at the front desk for $10, and if they don't work, bring them back, I'll give you your $10 back.
Now,
So
what
that
else?
was
Yeah, but you have a
that,
list of things to try and reset the circadian rhythm. You have a name for this. It's called the social rhythm therapy, SRT. And so there's more than one component to this fixing of your body rhythm. It's not just about amber glasses. Maybe you could share some of the other steps that people could employ to help reset their rhythm and improve their sleep.
certainly. So yes, the amber lenses are merely a tool to achieve the main goal, which is a regular bedtime and a regular rise time. That is what is setting your clock, that behavioral change, a regular bedtime and a regular rise time. The amber lenses are merely to make it easier to use that regular bedtime and not lie around for another hour afterward because your body hasn't reset its clock yet. The amber lenses are trying to help you reset your clock such that when you get in bed at that regular time, you fall asleep within 10 to 15 minutes. So the regular bedtime is the front end. The regular rise time is probably the most important component, but it's easier to get out of bed at a regular time when you've gone to bed at a regular time and slept most of the time in between. So in the social rhythm hierarchy of things to try to go for in terms of behavioral change, a regular rise time is numero uno. A regular bedtime is the thing that will help you get there. And then there's a series of other behavioral changes that you can make that further strengthen circadian rhythm, but they're nowhere near as strong as those first two. So I think when people are trying to do the whole social rhythm package, which by itself has a very strong mood stabilizing effect, I think akin to some of our medications, one study affirms that the hierarchy of behavioral change starts with the sleep timing, and then one can move on to regular meal times. And there's a whole now a system around scheduling meal times, something called time restricted eating, which can fit right into this whole circadian change program. So changing one's eating patterns, not necessarily one's diet, but the timing of it is another component. And then exercise and people, I think, are the other two remaining strong factors. There are a few more even beyond that. And if someone wanted to try to, let's say this, there's a workbook that was just written by the expert in social rhythm therapy. Have you come across this already?
I heard you talk about it in another interview, and I saw that she's released the workbook, right? It's what was her last name? It was, yeah, Holly Schwartz.
It's available through New Harbinger, I think, Press. So the social rhythm therapy workbook from Holly Schwartz gives the whole package. And Holly likewise says you start with the sleep because it's an central component, um, and it's one of the strongest light givers, the time setters for circadian rhythm. So start there.
Excellent. And you talk about something relatively ironic in that when you don't get enough sleep, you feel manic. When you oversleep, you can feel depressed. And so it's sort of counterintuitive to what we would think. So a lot of people who may be experiencing a lot of mania, they just throw up their hands and say, no, I can't reset my schedule. They enjoy feeling that sense of mania. And then you have on the other spectrum, you have people who are struggling with depression and they just want to sleep all the time and they really can't get into the rhythm. So I'm wondering if we could talk about, I did come across some of the studies where I think they might motivate people to employ some of these things. One was a very small study showing, I guess, that when people are in a dark bedroom, so that they are really regimenting their light dark rhythms, that they had half the rate of manic reoccurrence and they were able to better control their weight. So I'm not sure if that's a study you did or that you're familiar with. Maybe you can chat about
No,
that.
that's a Japanese investigator whose name I've always had difficulty pronouncing. So I apologize for not being able to give you his name, but a study from Japan, yes.
Are you familiar with the details of the study?
Somewhat. The author is a member of our International Society for Bipolar Disorders and presented that paper to our chronotherapy subgroup. Yes, so I know it.
Yes. And so that to you as a psychiatrist, half the rate of manic reoccurrence, that would be pretty substantial, I would imagine.
Oh, yeah, yeah, yeah. Very, very, very important.
And then there was
So
a Norwegian. Oh, go ahead. Mhm.
So you think, okay, dark bedroom. What are we talking about here? Really dark. As I recall, in that study, they quantified, so they had light meters. They sent people home with light meters in the study to measure the amount of illumination in their bedrooms. And what they found was, I can't remember exactly what the curve looked like, but the darker the room, the lower the rate of recurrence. So there was this doubling effect across the curve. But the bottom of the curve didn't really flatten until they got way down to very, very dark. Um, I think it was like 6 lux. And that is less than a candle, let's put it that way. You certainly couldn't read anything in that level of illumination. So we're talking about really dark. Now, so one of the things that I like to emphasize is some people hear about this like really dark bedroom and they go, well, I don't like to be in that dark a bedroom. Well, there's a simple solution for that. You can have a nightlight, but the nightlight can only emit an amber color, no blue, right? So a no blue nightlight, you can have as many nightlights as you want. That's the beauty of this. Understanding the blue light phenomenon means that you don't have to have real darkness. You just to have virtual darkness, meaning no blue light. So you can have a dark bedroom. You can have a light bedroom as long as it doesn't have blue light in it.
And there was a Norwegian study as well. I think I read about it in Dr. Hansler's book, 2016, and Newsweek had talked about it. And again, another small study using blue light blocking glasses. So separate from making sure your room is dark, do you know about this Norwegian study as well? Dr. Hendrickson, I think is his name, and he does a lot of
Yes,
research
indeed.
on
That's
circadian rhythm as
that's
well.
Her first name is Tune, Tone, Tune Henriksen from Norway. She saw the paper that we did. Dr. Hansler put me in touch with this graduate student at the university where he teaches. And she had actually done a randomized trial of amber lenses for insomnia. Um, and never published it, presented it as a poster once, which it was her senior thesis as an undergrad. I said, this paper, this is like the only randomized trial of amber lenses in the world. You got to publish this. And she said, okay, well, how do you do that? And so I said, I'll write it up. You've done the work. Give me your data. Let's write this up. And we submitted it to a journal called Chronobiology International, which seemed to me the logical journal. I didn't learn until later. This is like the premier journal for the field. And this dinky little study, like by an undergrad, they put us through 3 rounds of reviews to get this paper in publication. Anyway, so it's a fun story for me that I helped get the first amber lenses study into publication. And then Dr. Henriksen in Norway saw that and said, we need to do a full scale randomized trial in people who are being admitted to hospital with mania. And she proceeded, even though she's mother of 2 and a full-time psychiatrist. I have the utmost admiration for Dr. Tuna Henriksen because, I'm just in my practice and I'm just seeing patients, and I didn't bother to try to mount a randomized trial of amber lenses. So she did that, and the results are just mind-boggling. I'm not sure if you've seen that graph, but so there's a control group that gets a pair of plastic lenses that are sort of gray colored. And then there's the group half that get the amber lenses. And this is in addition to medication treatments per usual on their inpatient psychiatric unit. So people get admitted with mania, and if they consent to the study, they get randomized to get the amber lenses or the control lenses. The control lens group, their mania ratings over the first week are just about flat because I guess in Norway, they're not all that aggressive about trying to get you unmanic really fast. The amber lenses group, while the control lens is going like that, the amber lenses mood mania scores go like that. It's just, you couldn't see a more striking in 1 week result. It starts down the very first day, continues basically straight down. They get out of hospital sooner. They get out with half the amount of antipsychotic medications in that group. So that study was the one that said, okay, look, this thing really works. Amber lenses for virtual dark therapy for inpatient mania, a stunning result. It was rated as the most important paper of 2016 by the International Society for Bipolar Disorders.
That's fantastic. Now, going back to darkness and dark therapy, people can easily obtain these amber glasses, but what else can they do to make sure that their bedroom is extremely dark?
Well, so some people might be fortunate enough to live in a really dark place and don't have to do anything, but that's probably the minority of folks, certainly around the world. So then there's getting blackout curtains. So that block as much light as possible, and a really good set of curtains will do it to the point where you really wouldn't be able to see your way around without a nightlight or knowing where your bedroom is laid out. But that's in a more expensive undertaking, I think probably on the order of $100 maybe or more, and takes some work. And what about all the people who don't even own their home? So frankly, it sounds kind of crazy idea, but tinfoil will do it. So take tinfoil, Reynolds wrap, and just run it, get a couple of cartons and block off all of your windows in your bedroom so that it really becomes a cave.
That's
Um,
fantastic. I mean, it's very inexpensive.
right. So that's the simple solution.
Excellent. And you talked about going to bed at the same time every night and getting up at the same time every day. Again, this may seem unachievable to a lot of people, especially if they have a lot of mania, for example.
Or,
What?
or,
Mhm. Go ahead.
or one of the big downsides for going to bed at a regular time is that most of the patients whom I see have a trauma history of some kind. They have a horrible, uh, they don't like to think about what has happened to them in their lifetime. And lying in bed alone in the dark is a time when those memories tend to come back. Or if someone is really depressed, and we invite them to try to go to bed much earlier than their biological clock is currently telling them to do so, they get to lie there in the dark and listen to all these negative thoughts of their depression that they've been trying to avoid by being active during the day. So they're in addition to being manic, which makes people not able to go to sleep when they get in bed, I think the much more common reasons for not being able to, not wanting to do this, to go to bed earlier, is I don't want to lie there and listen to my thoughts and be alone with my thoughts. So I'll stay up and watch television and try to distract myself until I'm so tired that when I finally hit the pillow, I'm more likely to fall asleep. And now it's 2 or 3 in the morning. So
Yeah.
we
Yeah.
have several problems to try to address here. One is to try to get a regular bedtime, and then the other is to try to move it earlier so that a person's circadian rhythm more closely matches the rhythm of the sun and the moon, right? So is that making sense? So
Does
we
it
gotta
does. And I know you say to set it back like 5 minutes every day to try and get to bed at a more reasonable
right,
time.
right.
But I also, in saying that, I also want to address the idea that that people think that they're just naturally night owls, and I don't think that's true at all.
Well, so yes, we have some people whose physiologic makeup makes moving your clock earlier harder. So there are some people, in fact, bipolar disorders selects for these people who are physiologically night owls. If you leave them in uh, I don't remember exactly the research setup, but if you give people the opportunity to run their clock at their own behest, so you put them in a cave but it has electricity, and you say, you're going to be in here for a couple of weeks. Here's the televisions, and here's the internet, and here's the food and the refrigerator, and we've got you all set up. You just get to live in this cave, and you can go to sleep or get up whenever you want. Um, some people's clocks would be they are indeed night owls in the sense that every night they would be up 1 hour later. Every 24 hours, they would go to bed an hour later. So that when you come back 12 days later, their clock is upside down because they've been advancing their sleep hour, making it later, delaying their sleep hour an hour a day. So some people do that, other people don't. So that's the physiologic night owl, is the person who in a cave in a free running clock would go to bed an hour later all the time. And being a night owl in that way is very common amongst people with bipolar disorders. So we have to respect the fact that physiologically they are kind of like inclined to let the clock run aggressively later all the time. So they have to work harder than the average person to keep it from drifting later and later. And that's why the regular bedtime with an environment that fosters being able to go to bed and get to sleep is so important. So getting to bed at that earlier time and then keeping it there, we have to respect the fact that it's harder work for some people. That's true. The night owl people.
I heard in another interview that you did that you had talked about a documentary that's being produced maybe as we speak. Has that been completed as yet? As another
It is
resource?
being produced. It is being produced as we speak. Holly Schwartz, the world's expert on social rhythm therapy, is one of the, I think, 20 or so, 20 or 30 research experts in bipolar disorders who are interviewed for a film called Brainstorm the Film. So brainstormthefilm.com is the website. And I'm promoting it not because I have any financial connection to it, but because this is our opportunity to show the world the magnificent advances that have taken place in research understanding of bipolar disorders. And social rhythm therapy is a big part of that story. Chronotherapy as a tool for the treatment of bipolar disorder is one of the 5 main ingredients in the causes of bipolar disorder that can be addressed and changed. So we're very excited to tell that story in brainstormthefilm.com. There's a 15-minute preview that's up already.
Now, can you talk about any particular cases, especially like when I think about women who are breastfeeding and are up and down all night long, or even children? Maybe we can talk about those two cases. How can you adjust for circadian rhythm disruption in mothers who are nursing? And how do you help children who are born with a disrupted circadian rhythm because the mother may have had a disrupted circadian rhythm while she was pregnant?
All right, taking those one at a time. We'll take mom, new child, breastfeeding. Um, how do you not be awakened repeatedly during the night and really disturb sleep? Well, ideally, there's a man around, the father of this child, who's invested in this child's welfare, and will get up in the middle of the night and bottle feed with mom's pumped milk. That, I think, is the standard recommendation. Now, I should say this is not my area of expertise, but there are bipolar specialists who focus on maternal child management of this challenge. I think that's their first recommendation. And I think it's Dr. Colleen McClung, who's interviewed in our brainstormthefilm.com, who tells this story in more detail. And there are even, as you may have heard, maternal infant inpatient units when mom's symptoms are getting out of control, where they manage the whole thing for mom. So this has become a recognized, it's kind of amazing to think that we had to figure this out relatively recently, but moms need help when they have bipolar disorder and they have a child who is very young and needs them to be available for making milk for them overnight. So that's a mumbly way of saying, yeah, this has to be taken in a very deliberate way, and a man to help would be a great thing. And when there isn't such a person to help, it doesn't have to be male, I suppose, right? So someone needs to help mom be able to get sleep, even when baby needs to wake up and feed.
Yeah, I mean, it takes a village. And unfortunately, we're so isolated today that we don't really have that kind of social support or familial support to help mothers. You know, it's a
Yes, and I
lot.
apologize to all sisters and partners and grandmothers and grandfathers and all those others who might be part of that community. It doesn't have to be the guy.
That's great. So anyway, and the children, what happens? I talk to so many mothers who say, "Oh, my child doesn't sleep." Is it because they have nightlights, or what do you think?
Well, yeah, I would certainly start by going, okay, well, it's interesting. This is not part of the standard interview that gets taught to medical students, but it's a standard part of mine. How dark is your bedroom? Tell me about your bedroom, right? So we would definitely start there. And then we would go on to how much light, and particularly electronic device light, is being is this young person being exposed to in the hour or two before the desired bedtime? Because those two are relatively easily, these are accessible changes, right? So we can make the changes there that will help this young person stabilize their sleep rhythm. You can't make a person sleep, but you can foster the environment that will enable them to do so. So, the general principles of social rhythm therapy apply because we're trying to strengthen circadian rhythm as the starting place. And so, if I might digress, you have probably covered this in other recordings, but there are the two drives that make people sleep: the circadian rhythm, so that there's a drive to sleep when your circadian rhythm says to do so. But then there's the other drive that is the so-called S curve that says, how long has it been since the last time you slept? It's your sleep deprivation curve. So when your sleep deprivation curve, which has been going up since the last time you slept, meets your circadian curve that says it's time to sleep now, that's the ideal drive to sleep. Well, you need a strong circadian rhythm to match your S curve, your sleep deprivation curve, in order to fall asleep at that time. So we can strengthen your circadian rhythm by social rhythm therapy, and we can strengthen your S curve drive by making sure that there's been no napping um, during the day. This is what we would do for an adult, but I think in a young person, not a really young infant, but in a relatively young person, we'd say, okay, well, no napping, right? That will interfere with your S drive as well.
Yeah, I sit on the fence about napping. I think it can help some people, but I think it can also interfere with your night's sleep as well. Do you ever see where napping is therapeutic and it actually can help a good night's sleep?
Oh, oh, indeed. And the beauty is that that's an experiment that people can easily conduct. So how's your sleep when you nap? How's your sleep when you don't nap? What do you think of your results, right? Yeah, so lots of people. So for example, the powerhouse woman behind brainstormthefilm.com, she wrote the book Brainstorm, Sarah Schley, who has bipolar 2, and has had a fantastic working career after 25 years of intractable bipolar disorder because it wasn't diagnosed. So she takes a power nap 20 minutes every afternoon.
And it doesn't interfere with her sleep.
No.
No, well, that's good.
So I think it would be remiss not to talk about some medications or some protocols that my listeners could talk to their doctors about. So we're speaking in hypotheticals here because you're not their doctor. But what do you do to help stabilize somebody who is extremely manic or extremely depressed? And what kind of findings do you see with your patients using certain medications?
Thank you for the question and for framing it that way. True, I'm not offering specific advice. These will be general terms, but easy to speak in those, frankly, because um, this is the way I think. So let's think of this in two ways. There are people whose symptoms are so severe that they need to be addressed right now. And whatever risk we need to take in order to get those symptoms under control, we'll take it because the symptoms themselves pose their own risk. Or, no, these are symptoms that I've had for years. I've been struggling with this. I've been managing to make my life continue to go, even though I have these symptoms. I'm willing to take a couple of weeks in order to see if we can use the lowest risk approaches that I might have to continue. I know this has been around for a long time. I'll probably have to continue these medications for a long time, not necessarily lifelong, but for long enough to really get stable, at least for starters. Um, and that group of people generally wants to prioritize low risk and low side effects. This group is willing to tolerate risk and even side effects if the stuff really works and works fast. So, so the answer to your question, well, what medications might we consider? It depends on which group you're in. I'll speak briefly about the high risk group of medications, the powerful ones that work fast, but my interest is really in these people are going to be facing these problems for a long time. We need to prioritize the things that have the lowest long-term risk and the fewest, hopefully zero side effects. So the holy grail in this business is mood stability with no side effects at all and no long-term risks. And that points at a single medication, in my view. But we'll come back around to that. Let's start with this. Let's get rid of these symptoms first. So if a person gets admitted with mania, there are strong anti-manics that an inpatient unit will use. And they work really fast and they work for most people. And it's great that we have them. So these are the so-called antipsychotics. They work within hours to days, and it would generally be in an inpatient setting where we'd think about using them. They're not the ideal long-term preventive agents for the prevention of a manic episode. And in fact, the one that is, which is lithium, that can be used on an inpatient basis and works within a couple of days in many people. So that too can be used in this group. So we're talking about lithium and the whole family of antipsychotics. That includes aripiprazole, trade name Abilify, for example. I think that's probably one of the most common. Risperidone or its cousin paliperidone, the trade name Invega. One of the biggest guns that works really fast is olanzapine, trade name Zyprexa. And so we use those to try to get people unmanic. I'm a person who's admitted with severe depression, suicidal depression. This is a very dangerous condition. There are antidepressant medications that aren't antidepressants. And quetiapine has a trade name Seroquel is among the best in terms of its data on effectiveness as an antidepressant intervention. More recently, there's something called lurasidone, Latuda, that also works relatively quickly, has that quick antidepressant effect. But quetiapine in particular has a long-term risk of metabolic syndrome, raising weight, cholesterol, blood pressure, posing its own long-term risks. Lurasidone, less likely to do that, but not zero. So those are kind of like, I think of them as like the big guns, and we use them when we have to. I'm particularly interested in this other group that is really thinking long term. And has the ability to think long term because their symptoms right now are not so severe that we have to just do something right away. In this group, which I think is the vast, vast majority of people with bipolarity, the bipolarity that's causing mood problems, um, the name of the game is mood stability with zero side effects and no long-term risks. And there is one medication that can offer that. So to me, it's like this is the most obvious starting place for the vast majority of people with bipolar disorders. Now, I should say, not all psychiatrists think like this. In fact, I might even be in the minority as far as I can tell. So this is my opportunity to get on a soapbox.
Good.
So that medication is lamotrigine. Trade name used to be Lamictal. Lamotrigine is generic. It's been around for decades because it was originally an anti-seizure medication. So we know, I think, everything we need to know about its risks. It does not have any major long-term risks when it's used properly. That's zero long-term risk. There's nothing in our toolkit other than social rhythm therapy, for example, that can make that claim. So a medication with no long-term risk managed properly, and for most people, in my hands at least, no side effects. That's perfect. So let's go there. Now, again, you have to be in a position to wait to get there because this stuff does not work within a day or two or three like the big gun stuff does. So that's the starting point, Pam, as an answer to your question. Make sense so far?
So far, and I've heard you talk about lithium, but high dose, not so good. Low dose is better, renders better results.
Well,
And I don't know how many people are out there self-medicating with lithium and what type of lithium, but you're talking about prescription based lithium with a very specific low dose, correct?
correct. So amongst the medications for this group, they're where we can think long term. The next choice after lamotrigine in my head is low doses of lithium. And I'm definitely an outlier in this respect amongst my colleagues because low dose lithium is not even really recognized as a separate tool than full dose lithium that we would use for a manic episode or the prevention of another manic episode. So low dose lithium, which in my head means blood levels that are lower than the levels necessary to prevent a manic episode. We're not trying to prevent a manic episode. We're trying to use this as a mood stabilizer. We don't need those higher blood levels. So low dose lithium is the blood levels, like for a manic episode, we're talking about 0.6 to 0.8 to 1.0 on the blood level results, milliequivalents per liter. For low dose lithium, we're talking about 0.5 and less. And in this case, the absolute blood level really actually doesn't matter. It's subtherapeutic, but I don't care. What I'm looking at is, does this help? So we simply start at the lowest available dose for lithium, 150 milligrams in a capsule, and go up by 150 milligram steps, not very fast, maybe more quickly if people are a little more desperate, like going up every 4 days instead of every week or so, until either something good happens, keep that dose, doesn't matter that it's subtherapeutic, or something bad happens, a side effect emerges. Okay, turn the dose back down a step, and then let's watch for another week or two and make sure, nah, that really didn't help. At that level, which is the maximum fully tolerable level, it did not add benefit. Okay, it's gone. We'll taper it off in a week or two, and that'll be the end of that lithium trial. But we tried it. Now, in that way, it seemed to me that a lot of people would get benefit from low doses of lithium, usually as an add-on to lamotrigine, not by itself. One specific case where I think about starting with the lithium, we'll talk about that in a moment. So low-dose lithium is by definition, and handled in this way, by definition, zero side effects. How about risk? Well, low doses of lithium carry almost no long-term risk. I'd say almost because you have to be careful, check your kidney function, make sure your kidneys are okay before you start, make sure that they continue to be okay. But the probability of harming your kidneys with low dose lithium is extremely low, much, much lower than the full dose lithium story. What makes this not zero risk is that lithium, for about 1% in 10, can interfere with their thyroid function. And 1% in 10, that's a pretty big number. So checking thyroid function before starting lithium and checking thyroid once on lithium is a necessary part of using even low dose lithium. The lower the dose, we have one study, our own, that says the lower the dose, the lower the likelihood of the thyroid problem, but it's still there. So it does require some thyroid monitoring. So that's low dose lithium, lamotrigine, low dose lithium, and then we move on to other ideas. That's the way I think of it.
Right. And I've heard you talk about these other ideas, and there's some controversy over them, and that is the light boxes. Light therapy has been used for over 100 years. We hear about here in Canada, in Northern Europe, you have these light cafes that people use for seasonal affective disorder. So you have these light boxes that you can buy that offer different spectrums of the sun, but you have a cautionary tale around using these light boxes as well.
True. So, if I may, I think of light comes in three forms. Um, when we think about using it therapeutically like this, first, there's outdoors. Now, outdoors, even on a cloudy day, especially more down at our latitudes here in the state of Oregon and the United States, for example, outdoors has more light than people get indoors all day. A short period of time outdoors is better than a long period of time indoors. So we must not forget that there's a lot of light available outdoors. Now, at your latitude, on a cloudy day, um, we might have to think about augmenting that somewhat for some people. So remember, first step is to think about outdoors, because outdoors with a moving body, that has two benefits, not just the light side, right? Okay. So the second light tool that I think gets overlooked because we start thinking about the light boxes too soon. The second tool, besides outdoors, is the dawn simulator. Dawn simulators, a device that turns on a bedside lamp over the course of about 30 minutes while people are still asleep. The light goes in through our translucent eyelids and reaches the brain and says, it's daytime. It's time to think about getting up now. And if you have a regular a regular rise time, as you should, then the dawn simulator lovely complement to setting your circadian rhythm by telling your brain it's daytime, it's time to get up now. So the dawn simulator over 30 minutes before you actually wake up. By the time you wake up, the light therapy from a dawn simulator is all done. You don't have to wait around. You don't have to be pinned in one place. You just get on about your day as your social rhythm therapy rhythm would wish you to do. So a dawn simulator costs between $30 and $100. The $30 models work fine and have zero risk. So why would we start thinking about any other form of light therapy before we start thinking about a dawn simulator? So in my view, the beginning of light therapy for mood disorders is a dawn simulator. The only risk of a dawn simulator is that if your bed partner has a later schedule, they won't like you. And you can get them a sleep mask and say, okay, fine, you just stay asleep when my dawn simulator goes off. I say that partly jokingly, but so there is a potential social problem around these things. Otherwise, zero risk, very low cost. And then we can come to the light boxes. And I think most people don't need to go there after they do these other things like have a dawn simulator, get up, go outside and walk around. But if that isn't sufficient, and now we need to think about a light box, then as you described, Pam, there are some potential risks to this. The randomized trials say the risk is quite low, but that's because the risk that they're looking for is the induction of mania or hypomania. I think there's a different risk to all antidepressants that we need to monitor, and that is the induction of a mixed state. Antidepressants, the pharmaceutical pills and light boxes, can induce not just hypomania or mania, but a mixed state where there are some manic symptoms beginning to mix together with depressive symptoms. So and I think that's far more common using antidepressant pills, and I think it's probably the bigger risk using a light box. So a mixed state, what does that look like? The big four symptoms, the so-called four A's, a colleague of yours in Canada, Dr. Roger McIntyre in Toronto, calls them the four A's: anxiety, anger, agitation, and attention problems. These are symptoms of mixed states. So this is, I'm sorry, a long answer saying if one starts to use a light box, one has to be careful about the emergence of anxiety, anger, physical agitation, and attention problems as indications of a mixed state. Even while the depression symptoms might be getting better, if those other things are showing up, it means, uh-oh, we're entering an unstable realm. Um, we want the antidepressant effect without the induction of mixed states. And I think that would say time to be cautious about the light. And there's a way to fix that without giving up entirely. So if I may just finish this up on the light box,
Absolutely.
the original research on these things was done by using the light in the middle of the day, midday, 30 minutes with a standard light box, 10,000 lux within 18 inches. So that's the full dose of the light box, but it was done at midday because it was thought that doing it earlier in the day might have a more powerful circadian shove and be destabilizing. So one can make it less destabilizing by using it in the middle of the day, where unfortunately for many people it doesn't work. So if it doesn't work, you don't give up. You then advance the time so that you're starting your light therapy at 11 instead of noon, or then 10:30 or then 10, and you back the timing down toward the morning until either it works or it starts inducing mixed states and potentially hypomania or mania. So one can carefully adjust the dose of a light therapy, not by changing the distance or the intensity, but by changing the timing toward morning. It becomes a more powerful antidepressant when one does that. Does that make sense?
It does, it does. And I don't know if you know the answer to this question, but are they using UVA, UVB light, both, one or the other? What are they using?
To my knowledge, well, in those studies, this was 10,000 lux at 18 inches, and it was a standard light box with a UV filter, so there's no UV exposure.
Oh, okay. And do you know how long the therapy lasts
Yeah,
typically?
that was 30 minutes. So
Okay,
that's kind of
fascinating.
this the standard dosing for a light box is within 18 inches, 10,000 lux box that's got a filter for UV because UV can do damage, excuse me, can do damage to your eyes. And people who have a family history of macular degeneration need to be really much more careful about using a light box at all, and certainly have a UV filter on it. Otherwise, the color of the light really doesn't matter as far as any of the research that I've seen. Full spectrum really it doesn't matter. If it's white, it's got blue in it. It's the blue that matters. So you could use, in my opinion, you could use a little blue light box, which they used to have. Um, and I think that would be fine, but it's not standard. It's not been studied in the research mill. So, all right, we'll stick with if we want to do this and really do it right, according to following the research, we would use a 10,000 lux box at 18 inches.
Now, you wrote a book recently with Chris Aiken, Aikaen, Dr. Chris Aiken, Bipolar, Not So Much. We have this movie coming out, this documentary coming out with Holly Schwartz. What is your goal, if you will? I mean, this information is critical. It's got to get out. This is so important. Yet so few people know about it. People take light for granted. They take darkness for granted. They think they have a mental illness and they think it's just isolated to the brain. But they don't understand the connection between the eyes and the brain. What do you want to see happen? I mean, I'd love it if you could teach workshops to other doctors, other educational institutions to teach them about this critical information.
Well, thank you, Pam. And it makes me curious, of course, about how you came to understand all this. I'll ask you in a moment. I'll answer your question first. Um, so, Brainstorm the film is the major effort that we are undertaking right now. And the we is Sarah Schley, who wrote the book Brainstorm, which is a stunning memoir of bipolar 2, the best by far account of bipolar 2 I've seen in writing. There are many others and they're very good, but this one is such easy reading. I read the whole thing standing in one place, almost literally. Um, so Brainstorm, the book, and brainstormed the film is Sarah Schley. And Sarah and I said, hey, we should make we should make a video documentary for public television. That's Sarah's way of, that's the scale at which she thinks. And I've got a friend from college who's a video documentary maker who makes things for public television, Nova, so pretty famous director, and she's willing to direct this film for us. So we just need some money. So let's go get some money. And Sarah and her team got $1.2 million within the space of a year in private donations. That is apparently in the film industry absolutely unheard of. But so we now have full funding for this endeavor and brainstormed the film. Bonnie Walsh, the director, and Sarah trucked around the world and interviewed bipolar specialists and in all of the 5 angles of what causes bipolar disorder and what can we do about it. And I'll tell you about those 5 angles in a minute. So Brainstorm the Film is like a description of bipolar disorder in exactly the way, Pam, that you and I would wish the general public to broaden its understanding. It's a film about the bipolar spectrum. So that would come out in early 2025, and we're angling for, in the United States, the public television network. We'll have to think about how to do this in Canada. I think right now it's PBS that we're angling for. But once this film is made, we're going to try to get it out into as many eyeballs as possible, of course. That film effort includes, we're going to make shorter things that are targeting specific audiences, including primary care providers, psychiatry. But I know from personal experience, having tried to do this for 20 years, it's hard to get to them. It's actually easier to, thanks to people like you, get to patients and families who need this information. That's actually been easier to do. I had a website that I ran for 20 years and just created a new one to try to make the whole message shorter. And so you could put this in your show notes. It's depressioneducation.org.
Thank you.
Depressioneducation.org is as short as I can make it story of all the stuff that we're talking about today about, okay, you're depressed. What kind of depression do you have? How bipolar are you? And depending on how bipolar you might be, what kind of treatments might you consider and what are their pros and cons? So depressioneducation.org is one of my efforts. Brainstorm the Film is one of my efforts. And then because people don't read books anymore and they don't even read websites anymore, especially if they're too long. So they want a video. So I'm also trying to make a whole collection of videos to take all this same information and pass it along. So that's the Psych Education YouTube channel. So there's a YouTube channel called Psych Education. And I'm slowly making videos to try to tell this whole story. The dark therapy story, the regular bedtime, regular rise time story, those are already there. So videos, the same conversation that you and I have had, but in practical terms, exactly how do you do this? That's up on that Psych Education YouTube channel now.
Excellent. And I've talked about my story in other shows, but for me, a trigger was mold. I was living in a really moldy apartment in London, England. I live in London, Ontario, but I was on a European tour after university, and I lived in a moldy apartment, and I got terribly, terribly sick, what would be called today long COVID. And I just had terrible, terrible insomnia for years and years and years. Couldn't sleep. And I
Wow.
tried everything, and I knew that it was important to go to bed at the same time and I'll get up at the same time, but it was impossible to do. So I work with a lot of clients who have chronic fatigue, fibromyalgia, and have a lot of sleep problems. And some would have a diagnosis, whether it be anxiety, depression, ADD, ADHD. They'd have a host of different labels potentially. But I think that sleep is the bedrock. I think that we have to fix sleep. And to fix sleep, we have to address some of these tactics that you've talked about today. And once you can stabilize sleep, I think the benefit is going to be improved energy, stable mood, et cetera, et cetera.
Right. Okay. I totally get it. I totally agree. You may choose to edit this out, but having mentioned ADHD, severe anxiety, I would want to point out that if you look at the symptom set for ADHD plus depression, what symptoms does someone have if they have ADHD and depression? That symptom set almost exactly matches a bipolar mixed state. In fact, the overlap is so complete, they're impossible to tell apart by looking at symptoms. So if someone has ADHD and depression and they're doing well, great. Don't even listen to this. But if someone had ADHD and depression and they're not doing well, then everyone in that setting, I think, should consider, maybe what about this bipolar mixed state thing? It's depression plus some manic symptoms, not bipolar. It's just depression plus some manic symptoms, anxiety, agitation, um, anger, and attention problems. When you mix those together, that's what makes it look so much like ADHD with depression. But the treatment for that is very different than the treatment for this. And so if treatment is working really well, fine, listen not. But if treatment is not working well, then it's worth thinking about, is there another explanation for this that leads to other treatment possibilities? And this whole story that you're trying to tell about managing sleep and managing light and darkness is a very important ingredient in that treatment set.
Now, to finish off, because I've taken up a lot of your time today, I'm wondering if you can share with our listeners what what your perfect circadian day would look like.
I laugh because, oh no, I'm going to have to explain the pickleball thing.
I'm a tennis player, so
So I used to be a tennis player, and I now play this game called pickleball that we are doing a lot here in the United States. Um, and I enjoy it vastly more than tennis, I'll have to confess, because there's a social angle to it. You get to the net and you're not far away from your opponents, and the points go on much longer. And so there's this whole "what am I thinking? What are you thinking?" game going on. In any case, so I play a lot of pickleball. So that's part of my regular circadian rhythm is really vigorous physical activity, which I'm very fortunate to be able to continue to pursue at my age. And I'm aware that not everyone can. But so some kind of physical activity is in that circadian day. And then Sarah Schley, the bipolar 2 author, would say she calls them HECs. Let's see if I can get her acronym right: physical, emotional, creative, and spiritual. Her daily PECs: physical, emotional, creative, and spiritual. And she tries to do something of each of those every day. These are described in her book, Brainstorm. Um, so, yes, you're right. There is a rhythm to this, and the ideal rhythm includes physical activity, something that is emotionally fulfilling, some creative outlet, hopefully, and a spiritual connection to others and the world. I think I'll let Sarah's answer be my answer.
oh, that's beautiful. Well, thank you so much for the work that you're doing and sharing it with the world. I'd love to have you back on with an update maybe 6 months from now to see if the movie is making headway. I'll do what I can to share the information about the movie because the more people that watch this, the better. And
Yes,
your YouTube channel as well. You offer a lot of this information for free, and it's really just about application.
yes, indeed. I agree. We're on the same team, the same wavelength, that's for sure, Pam.
Okay, thanks so much for joining me today. Thank you for taking your valuable time to join us today. The information provided on my website, community forum, and podcast is intended for informational purposes only and should not be construed as medical advice. We are not licensed medical professionals, and the content shared here is not a substitute for professional medical advice, diagnosis, or treatment. If you are seeking health advice or have specific medical concerns, we strongly encourage you to consult with a qualified medical doctor or healthcare provider. They are trained to evaluate your individual health needs and provide personalized recommendations tailored to your unique circumstances. By accessing and using my website, participating in my member forum, or listening to my podcast, you agree to acknowledge and abide by this disclaimer. We do not assume any responsibility or liability for actions taken based on the information provided herein.